Hi viewers, welcome back to our channel A to Z Dentistry Dental Lectures Medicine. Today's topic of discussion is Peripheral Ossifying Fibroma. As the name suggests, it is a benign lesion. Ossifying fibroma occurs mostly in craniofacial bones and it can be categorized into two types, either central or peripheral. The central type of ossifying fibroma arises from the endosteum or the periodontal ligament, which will be present adjacent to the root apex and expands from the medullary cavity of the bone. The peripheral type occurs on the soft tissues overlying the alveolar process, that is our gingiva. Synonyms for peripheral ossifying fibroma: peripheral odontogenic fibroma, peripheral cementifying fibroma, calcifying or ossifying fibroid epilys. Peripheral ossifying fibroma is a non-neoplastic enlargement of gingiva that is classified as a reactive hyperplastic inflammatory lesion, a common gingival growth which is typically seen on the interdental papilla and is believed to comprise about 9% of all the gingival growths. Now we will see what all are the gingival growths we are having. It can be either giant cell fibroma or peripheral giant cell granuloma or pyogenic granuloma or simple fibroma or healed pyogenic granuloma or peripheral ossifying fibroma or peripheral odontogenic fibroma. Peripheral odontogenic fibroma now considered in odontogenic tumors. So that is declared by WHO. What all are the key features for peripheral ossifying fibroma? We will be having high degree of cellularity. There will be bone formation or cement-like material formed in their area, or sometimes we will be getting a dystrophic calcification. Despite the similarity in terminology, it is not considered to be an extraosseous counterpart of the central ossifying fibroma. The reason why is central ossifying fibroma is true neoplasm. This is an reactive lesion. 2% of the total oral lesions comprised peripheral ossifying fibroma. 9% of the total gingival lesions that we have enumerated earlier comprised of POF. So who all are prone for this? Children and young adults. So approximate age group is second and third decade of life. Female to male ratio, it can be either 2:1 or 3:2. It can be occur on maxilla or in mandible. Coming to the clinical features, we can see a well demarcated, very slow growing, solitary focal mass which is present on gingiva. It can be either sessile or pedungulated lesion and interdental papilla may be involved. The surface of the lesion may be intact or sometimes it may be ulcerated. The picture shows peripheral ossifying fibroma on maxilla. Coming to the histopathological part, regarding surface epithelium, which may be either intact or ulcerated. Connective tissue stroma, we can see large number of plump proliferating fibroblasts intermingled throughout a very delicate fibrillar stroma. High degree of cellularity than fibroma, so we can differentiate it from fibroma. Vascularity is present, but it is not nearly as seen in pyogenic granuloma, but it is more than that of fibroma. Calcification, single or multiple interconnecting trabeculae of bone or osteoid or globules of calcified material which is similar to cementum. Sometimes you will be getting diffuse granular dystrophic calcification. The picture shows above mentioned features. H&E section reveals a highly cellular connective tissue with ossification in the form of a cellular basophilic cementum-like material. This is another picture which is also an H&E stained section which reveals highly cellular connective tissue with ossification in the form of irregular trabeculae of woven bone, osteoid and a cellular basophilic cementum-like material. Now we are moving towards the treatment aspect. We have to eliminate the local irritant which is producing it, and we can do a simple surgical excision for this particular lesion. Thanks for watching.